Greetings. Thank you all for taking the time to watch this video about psychiatric disorders after head injury. This is going to be brief and review a few highlights. We could certainly spend hours and hours and hours talking about these types of things. So again, I just wanted to go over some brief information that may be helpful to you. Certainly, if you have any additional questions, you're free to contact me and ask whatever you might like to ask me, okay? A few disclaimers before I get into this video. First and foremost, nobody is paying me to do these videos, okay? There's no financial disclosures related to these videos. That's number one. Number two is I am recording from a temporary office space for the moment. So just in case you wonder why I look like I'm in, kind of looks like I'm in a closet. I'm really not. It's actually a big open office space. Just for the moment, it looks like I'm backed into a corner somewhere. I have a fridge behind me full of medications. And because I am in the office, there may be interruptions and this may be choppy and not very fluid. So I do apologize for that if that happens. Also as well, again, this is not any type of academic presentation, okay? Anybody out there who is a healthcare provider could frankly rip this apart, okay? Because I'm not getting into medicine. I'm trying to present this to the general public and the best that I can just to make a few points. So thank you for stopping by. I hope you do learn something, and actually, if you do have some questions after this, that actually would be a good thing if I could perhaps make this thought-provoking. We're going to go through Theresas' story here. Now, I want to make it clear that Theresa is not her actual name. Theresa is a real patient, but of course I made up a fake name to preserve this individual's privacy. When I had seen Theresa for the first time, she was a 55-year-old woman who'd already been evaluated by a nationally recognized concussion program. I'll be honest, as sort of a red flag when I see that, because I often have to wonder, am I really going to do better than a nationally recognized program? You know, if you've already failed something that is sought out by celebrities and athletes from all over the country, I'm really not sure what I can do for you. However, this may not surprise you all. Some of these nationally recognized programs, they treat the celebrities and the professional athletes maybe just a little bit different than the average Joe. That probably doesn't surprise you all. Anyways, Theresa had a number of head injuries in her lifetime. She had a rollover car crash. She also had been subjected to some abusive head trauma in a prior marriage. As far as Theresa's psychiatric history, she carried with her a diagnosis of bipolar disorder. She suffered from, I'd say, pretty severe anxiety, and she also had a history of PTSD. In addition to the history of head injuries, Theresa had also been subjected to sexual assault in her life. So she had some physical and mental traumas in her life. The reason Theresa was sent to me was for headaches. This is sort of what I call a Trojan horse referral, and I'll explain what I mean by that in a moment. She also had some problems with balance and disequilibrium and vertigo and those types of things. Problems with sleep, chronic nightmares, insomnia, and some pain issues. Okay, she was seeing a rheumatologist for fibromyalgia, and also had some back surgeries in her life too, so some chronic back pain. Now let's go back here. Let's see if I can pull up a little pointer here. She was referred to me for headaches. Now let me ask you all something. Do you think when Theresa sat down and had a discussion with me that we just talked about her headaches, that we didn't have to delve into some of these other issues to get to the root of her problem? So that's what I mean by a Trojan horse referral. Sometimes the doctor says, you know what, we'll just put headaches on this referral, ship it off to the neurologist. The next thing you know, I'm treating headaches, balance disorder, sleep issues, pain issues, you name it, okay? Those other issues are kind of hidden inside that Trojan horse. Happens all the time in practice, such as mine. So we just have to deal with it. Okay, now before you look at this picture here and think, oh man, it's a medical picture, it's a diagram, he's trying to teach us biology 101. No, I'm not, okay? It looks very complicated. I'm going to make it very simple for you, okay? You don't really have to learn anything here. All this picture points out, I'll break it down for you very simple. Within your brain, deep in your brain, there's two critical areas. The hypothalamus and the pituitary gland. The hypothalamus sort of tells the pituitary what to do, and the pituitary tells all the other glands in your body what to do. Okay, and what we're looking at here specifically is your adrenal glands, okay, how your adrenal glands function, how they release cortisol. So if you do look at that diagram, they're up all the way off to the, we'll get a little pointer here, right, all the way right here, this little stress, right? When you're subjected to stress, some type of stressor, and your brain perceives that, right, eventually your adrenal glands are going to release stress hormones, okay? So if you're startled, right, if you're driving down the highway and somebody pulls out in front of you and you hit the brakes, right, and then you feel your heart jump and you kind of get that rush of adrenaline, that's normal. That's supposed to happen, right? Because that fight or flight feeling is protective, okay? If you didn't have that feeling, you wouldn't get scared, you wouldn't hit the brakes and have an opportunity to avoid a serious car accident. So that's actually a good thing, okay? However, here's the problem here. If you have this little flaming ball here where you have stress all the time, constantly under stress, constant stress and anxiety, it's just constant, non-stop, you're going to release some cortisol. You're supposed to, but let's imagine in a scenario it's just happening all the time, 24/7. You're just under stress and anxiety non-stop, okay? So what's going to happen eventually is a disaster in your brain, because so here's the thing here, okay? Again, this little hypothalamus here is in your brain, in your pituitary gland. You know, they show a little blown up picture here, but it's actually kind of up here in your brain, okay? The anterior temporal lobe of your brain is responsible for consolidating memories, okay? So think of it this way. If I ask you to remember my phone number, if I give you 7 digits, your anterior temporal lobe takes that 7-digit number and holds on to it for a little bit of time. If you want to remember it for the rest of your life, it consolidates it and sends it up to your frontal lobes as a storage locker. So what's going to happen here, if you're constantly under stress and anxiety, constant, non-stop, in this cortisol here is just constantly going back here and bombarding the anterior temporal lobe of your brain, it's going to shrink. It's going to atrophy a little bit. Not enough that you would see it on an MRI. See, this is the question I get all the time from patients. How can I have a normal MRI? I know I hit my head. Because the damage to your brain, it's on a microscopic level. So this does cause a problem when people have this constant stress and anxiety. This is why people come and say, well, that famous question, what about my memory? Well, what about it? This is part of the problem, okay? This constant stress can affect your memory. This constant anxiety. However, one problem begets the other problem, okay? Because one of the things people forget here is that most people have what we call an acceleration-deceleration injury, right? So in that scenario where I'm driving down the road in my car, right, and I hit the brakes, suddenly I'm going to move forward and go back, right? That acceleration-deceleration injury. So your brain actually does move back and forth, okay? So we focus all the time on, this cortex of the brain, it bouncing off your skull, but right here in the center here, that's a nice little axis for things to go wrong, right? That hypothalamus, that pituitary area, what if I really took a hit? The concussion can affect that area too. So we always have to keep that in mind as well when we're thinking about memory issues, anxiety, and even other endocrine functions. Certainly I've seen people with sleep problems and adrenal gland problems that theoretically have come from a concussion to the deep parts of their brain. Thank you, Adam Sandler and Dan Aykroyd, for making the amygdala famous from the movie 50 First Dates. It's a good laugh for people who know what it is. For everybody else, I'll give you an explanation. The amygdala is an almond-shaped structure that also resides in your temporal lobe of your brain, okay? It has a very specific function. It basically records your fears, which can be a good thing, right? Okay. If your dog places his paw on the burner of your stove and yipes, ouch, the reason why he doesn't do it again is because his amygdala reminds him that bad things will happen if you do that again. So there's a couple of little circuits in the amygdala, and again, I don't want to get into the science of this. We could do that. There are two circuits here. One is fear, and one is fear extinction. Okay, and from a scientific level, there's three little areas here. The stimulus of fear kind of skips over the middle part and goes right to here you go. You're going to be afraid of this thing forever. It's in your brain forever. And fear extinction is going to be, let's kind of retrain this a little bit to let's find a way to forget about it, or not really forget about it, but modify it. So this is a little bit tricky, and let's see if I can go over a scenario here. So let's say a zebra is out on the savannah minding his own business, and he wants to have a drink of water. He sees a lion coming. Obviously, he's going to be afraid, right? And we're going to have that fear circuit go off, which is actually a very good thing, because you see, if a zebra wants to survive, he has to know to be afraid of lions. He has to know that every time he goes to take a drink, he better be watching out of the corner of his eye for a lion. He's going to have that fear, right? And when he's taking a drink of water, he's probably going to have a little bit of a fear response, right? I mean, yeah, he's going to enjoy having a nice drink of water, but he's also going to be kind of looking out of the corner of his eye. Maybe a tree will move in the wind, and he'll think, oh, was that a lion? He'll get a little bit scared, a little frightened. And again, that's actually a very good thing, because this is how the zebra survives, right? But in the cases of post-traumatic stress disorder, imagine reliving that fear over and over and over and over again, right? It's not healthy. So when we talk about fear extinction, we're talking about things such as cognitive behavioral therapy and exposure therapies. Now, let me explain what exposure therapy is. Very powerful stuff here, okay? Exposure therapy is basically facing the fear. And if I go back to Theresas Story, right? When she sat down with her counselor, when they encouraged her to talk about some of the abuses that she went through, the sexual assault, the physical abuse, and probably mental abuse too from a former spouse. She got to the point where it's like, well, I can only go so far, right? Sorry, you're going to have to go all the way. You're going to have to let it out. And I'm not a psychiatrist for a living. I'm not a psychologist for a living, but I've certainly been to some lectures by individuals who do this type of therapy. And they say it's very cathartic for the patients. Patients will yell, patients will scream, patients will do all types of things. You know, there might be people out in the waiting room thinking, man, I wonder what's going on in there. But ironically, when it's all over, they feel better. They actually do feel better. So it's actually a very good thing. Now, what I also have here, the drugs propranolol and prazosin. These are things, again, if we start getting into medical literature, that may sort of shut down this fear circuit, because norepinephrine is the hormone involved in that fear circuit, so these kind of shut it down. Prazosin is very good for people with chronic nightmares, right? That has been well studied, because the idea is you're going to sleep at night and you got that norepinephrine going. It's going, it's giving you all these nightmares and you're constantly reliving these traumatic events. That sort of shuts it down. So I actually do use prazosin for these people who do have chronic nightmares, because I do find it very helpful for that reason. But going back to the exposure therapy for a moment, I would recommend two books. One is called They Can't Find Anything Wrong. I can't remember the author, I'm sorry, but it's written by a gastroenterologist, and all throughout his book, I'll spoil it for you a little bit, he goes through case scenarios of people who had chronic abdominal pain and issues that were really tied to traumatic events in their life. And he would encourage people to just let it out, maybe actually confront the person that caused them the traumatic event in their life. If they didn't want to do it, maybe write a letter to the person, never send it, and he would find those things very helpful. Versus Howard Schubinger, who wrote the book Unlearn Your Pain, and I think he has a version that's very similar, Unlearn Your Depression and Anxiety, talks about how he would ask his patients, well, what would you do, right? Okay, if you were theoretically, let's just make up a case here, okay? If somebody sexually molested you when you were 5 years old, and you had to deal with that psychological trauma all your life, what would you do if that person was in the room right now? What would you say to them? What would you do to them? And these people who were mostly nice people would come up with very graphic things. They'd say, pardon my language, I'd kill the bastard, I'd stab him to death, I'd rip him apart, I'd tell him this, that, whatever obscenities. And again, you'd hear the screaming out in the waiting room, wonder what's going on in there. But again, same type of result. They'd get it out and they'd feel better. So I do believe that if you're having some PTSD, that you do have to face these exposure therapies. But again, in the cases of head trauma, where you're reliving your physical trauma, and of course there's going to be some mental traumas that come into these things as well. When you're doing it over and over and over again, obviously that's not healthy. Sure, we could give you the drugs, right? We could give you the prazosin, the propranolol, but there's only so much they can do for you, okay? It's not all about just giving you drugs. You do have to go through some therapies, cognitive behavioral therapies and exposure therapies, to try to help. Again, you can't really get rid of these fears, because once this zebra gets scared of this lion that tried to eat him, that fear circuit is burned in forever, okay? The other part of this is trying to dull it, okay? Maybe that's the best way for me to explain it. I'm going to talk about pseudobulbar affect for a few minutes, or PBA, because I find this very fascinating, and I find it to be underdiagnosed and underrecognized by neurologists, psychiatrists, or any physicians that manage head injuries. There is a drug on the market called Nuedexta, and I have no financial affiliations with Nuedexta. I don't make money if you go out and get a prescription for Nuedexta. I don't make money if I write a prescription for Nuedexta. I just wanted to put that out there. But the only reason I mention that drug by name is because you've probably seen the TV commercials for this drug, right? Over the years, being a neurologist, we've seen people with Alzheimer's and Lou Gehrig's disease and multiple sclerosis that may have had PBA. So what happens here, and again, you're looking at this picture thinking, oh, great, here we go again, more science. All this picture is showing you is this, okay? Between your frontal lobes, your cortex, right, all the way down here at this part of your brainstem, your pons, and your cerebellum, this whole circuit here, okay? If you break that circuit at any point in time, you can get PBA, right? So people who have Alzheimer's, well, their frontal lobes and their temporal lobes and their parietal lobes are actually shrinking, okay? They're being subjected to atrophy. It breaks the circuit. If you have a big stroke here of your brain stem, it breaks the circuit. If you have some type of condition that affects the cerebellum, you break the circuit. If you had a pretty significant head injury, such as an acceleration, deceleration injury, or even a rotational injury, we forget about that, right? Okay. You know, if I'm a boxer and somebody, gives me a good punch, or my head's going to whip that way, kind of that rotational shearing of the brain, which is going to be more down here at the brain stem, right? I'm going to break that circuit. So what you see in these Nuedexta commercials, you see the person laughing and crying inappropriately. So the idea is to laugh when it's not really appropriate and to cry when it's not appropriate, which can be very embarrassing for somebody. And I put this link in here. It's a questionnaire, the CNS-LS questionnaire. If you really feel that you might have this condition, or you feel that one of your loved ones might have this condition, please download this questionnaire and fill it out, because if the person has a high score, you need to take it to your local healthcare provider and address the issue. What I'm going to share with you next is my opinion. Not a fact, but my opinion that happens to be shared by other people in my profession. With PBA, we focus so much on outbursts of laughing and crying. I think it's more than just laughing and crying. I've seen people with outbursts of inappropriate anger. Inappropriate outbursts of other emotions. I think it all kind of goes along the same spectrum, and I think those people do just as well if I place them on a drug such as Nuedexta than the people who have the pure laughing or the pure crying, okay? I'm a believer in that, and it's very conservative because, if you do want to get into the science and the pharmacology of this medicine, it does have a little bit of an SSRI effect, and a little bit of an antidepressant effect. So just for what it's worth, look, I used to be a military guy, okay? And I'll explain to you what my frustration in the military always was. You have, and I'm sorry I'm digressing for a moment, but I am going to make a very important point, okay? You have a guy, a soldier who's young, in his 20s, relatively healthy, right? Before he was subjected to a blast injury or some type of head injury, he was a very healthy, fit person. So what happens when these people come back from their deployment, right? They go through a post-deployment assessment and they sit down and tell somebody, oh, I can't sleep. Can't sleep. That maybe they get a depression screening, a PTSD screening, maybe they screen positive for these things. So the doctors or the physician assistants in the military setting say, okay, buddy, here you go. Here's your antidepressant and here's your drug for sleeping. And then the guy says, yeah, but I'm anxious all the time. I'm panicking too. Okay, I tell you what, we'll give you a little Xanax for your panic attacks too. Okay, so now you're on 3 drugs. And the guy says, but what about my headaches? So then you go to the neurologist, you end up on 1 or 2 drugs for your headaches. And then the moral of the story is this. you have a guy who was a perfectly healthy 20-something-year-old guy that next thing you know, he's on 5 drugs all at once. Now, you can't tell me that that's not going to have some type of negative effect on the person. I mean, yes, you're trying to help the person at the end of the day, but if the paradigm is, well, you can't sleep, here's a drug, you're depressed, here's a drug, you're anxious, here's a drug, you got headaches, here's a drug, and how about trying something that can do it all? Okay, so I am a believer, just my own opinion, that sometimes this new deck stuff can be useful for particularly if somebody does have outbursts, right? Listen, I'll be honest with you. If you come in my office and you're busting out in anger on me and then start crying, I'm probably going to start thinking about putting you on this drug. And I bet you that in addition to controlling your outbursts, it might help with your depression a little bit. I'd even go a little bit further to say it might help with your headaches too, if that's your problem as well. But that's a different story for a different day. So at the end of the day, let's ask the question. If I had a good head injury, if I took a good crack to the head, can I have psychiatric issues afterwards? Well, I guess it depends on who you ask here, because according to medical studies, 33 to 48% of people are going to have some type of issue, and it could be anything. It could be depression, it could be bipolar disorder, anxiety, or this PBA that we just spent a few moments talking about. So here's a question. If we go back to my patient Teresa for a moment, she came walking in with a diagnosis of bipolar disorder. So is Teresa one of the various people in the world that just happens to have bipolar disorder? Or was it all a result of her having multiple head injuries? Truth is, you're never really going to know, and teasing it out can be a little bit of a problem. And you have to be very, very, very careful how you approach these types of things because, and again, I'm not a psychiatrist for a living, but anybody out there watching this video that does have bipolar disorder, or if you know somebody that has bipolar disorder very well, maybe a family member, a friend, or a loved one, you know that if you screw up one medication, you could really set that person into a manic episode and ruin their life, okay? They end up in the hospital and it's not pretty. So you don't want to have that happen. You have to be very, very cautious of how you approach these patients. But there was a good lecture from a psychiatrist, and unfortunately I can't remember his name right now, that he runs a transcranial magnetic stimulation clinic for refractory depression, and he has stated in his lecture that he's very surprised how many people, if he just asked them, at some point in their life had a history of head injury. So again, you have to ask, are these people really those individuals that just happen to have major depression that's refractory to every drug? Or is this a result of a head injury? Or is it a little bit of both? You know, you really don't know. And so you can see how this can be a little bit complicated. The problem here for myself and many individuals is this, okay? There are certainly psychiatric sequelae of head injuries. And if you are a person who just happens to have maybe just a little bit of depression, or maybe you're destined to have bipolar disorder and you're showing a little bit of symptoms, one of the ways I could really enhance that for you is to subject you to a head injury. And again, I've made the disclaimer many times, hey, I'm not a psychiatrist. That's certainly my observation. But I am a neurologist, and I would definitely tell you that if you do have migraines here and there, you know, like many people have, subjecting you to a head injury is going to enhance that process for you. So again, it can be very, very complicated whenever approaching these types of patients. So again, if we go back to my patient Teresa here, she was referred to me for headaches. Next thing you know, we're talking about all these other things and all these other problems, and certainly it takes a great deal of time to address these things. So it is what it is, and That's really what it comes down to a great deal of time. What I tell patients that I see is that when you go to some of the major centers, say places like the Mayo Clinic, you're going to get a 3-hour appointment, and you're going to meet with a neurologist and the vestibular therapist and a physical therapist and all these people. I don't have that luxury in my setting, so the best I can do for you are frequent and close follow-ups to really get into the guts of these issues and see what I can or can't do to help you. So is it all about the drugs? I'll tell you what I know. I'll tell you what's out there in the medical literature, okay? Paroxetine is an FDA-approved drug. It is an antidepressant that is FDA approved for usage in the setting of concussion and head injury. Unfortunately, it can cause some cognitive impairment and some sedation, so I don't particularly like to use this. I would say my observation is that sertraline, or the brand name Zoloft, tends to be a little bit better. I'm not opposed to using stimulants such as methylphenidate at times. We have to be very, very careful with that. Okay, it is a controlled substance. I'm not just going to give it out to anybody, but certainly it does have its role and can be very helpful for people. I'm going to point out this bupropion here, or the brand name Wellbutrin, this 2D6 inhibitor. So you're probably thinking, what on earth does that mean? Okay, look, your liver has a whole bunch of enzymes in it, and 2D6 is one of those enzymes. And your liver eats medicine, okay? Most medicines that you take, your liver is going to eat most of the medicine, and a little bit of it's going to pass the liver and get into your bloodstream, okay? If we go back for a moment to that drug Nuedexta that we talked about, that is used for pseudobulbar affect, if we shut down, Nuedexta gets metabolized very, but let me just back up. I screwed that up. I apologize. Nuedexta is a combination drug. Dextromethorphan is part of that drug, and that is really the major component that you want to get into your brain, okay? You can get dextromethorphan in cold medicine, right? But the truth is, a great deal of that medication is going to be metabolized and eaten up, and very, very little of it's going to get into your bloodstream. If you shut down 2D6 in somebody's liver, a good deal of it is going to get into your bloodstream. So that's basically what the quinidine portion of that drug Nuedexta does. The quinidine shuts down 2D6, and that dextromethorphan gets into your brain and has some very positive effects, I believe, okay? So sometimes if people can't get their hands on Nuedexta, sometimes a little bit of Wellbutrin with a mix of dextromethorphan can be a little bit beneficial as well. For anybody watching this video, please don't try that at home, okay? So I guess what I'm telling you, if you ever seen that Dr. House episode where the guy was slogging down a bunch of cold medicine to purposely make himself stupid, it actually wouldn't work, okay? Don't try this stuff at home. Don't do your own pharmacology. Please consult your local physician before you do anything like that, okay? And certainly, some of you may laugh at this, but this is the obvious. If you're looking at this and saying, well, gee, he said Zoloft might be a little bit better than paroxetine, I think I'll borrow my grandmother's Zoloft. Please don't do that either, okay? Just go to your doctor and talk to them about it. And especially don't borrow your friend's stimulants, such as methylphenidate or Adderall. You'll get your friend in big trouble. Please don't do that. Okay. Anyways, some of these drugs here I have bold, such as the doxepin and amitriptyline. I use those medications sometimes for refractory migraines. So again, going back to that, can I treat multiple problems with one drug? Sure. I can put somebody on doxepin, which is FDA approved for insomnia, and help them sleep. and help with their headaches, right? So I do actually try to be conservative. Again, thank you for watching this video to the end. I've been talking for over 30 minutes now, and believe me, I could go on and on and on and on. I could really delve into these topics in much more detail. I don't want to bore you all to tears. Like I said at the beginning, if I could stimulate a few questions out of you all, or a few thoughts that you'd walk away with, or a few curiosities, that's a good thing. Certainly take the time to explore those things on your own. If you have any questions for me specifically, you can click that link. That will get you in touch with me through a telehealth messaging service, and we can talk about whatever it is you would like to talk about, okay? Other than that, have a nice day. And again, thank you very much for enduring this video.